When you inject second time, it has a better outcome. So what usually I inject is shin cord with lignocaine 1% under aseptic technique. But you must remember about the complications. They can have hyperpigmentation, fat atrophy, and also tendon rupture if injected many times. So we don't recommend more than 2 injections. So if you've tried 1 or 2 failed, please refer out.
Is at number 7. Okay, and then if you look at 5, 6, this is so 6 is your CFL, your calcaneofibular ligament, and it actually kind of does have some connection with the ATFL as well, and it attaches to the tip of the distal fibula. Number 1 and number 2 is your syndesmosis, right? Anterior syndesmosis ligament, and you also have your posterior syndesmosis ligaments, which we call the PITFL, posterior inferior tibiofibular ligament. So the anterior syndesmosis is called the AITFL. So here you can see the anatomical dissection as well as the drawing of it. Okay, so they are actually very, very strong ligaments, these syndesmotic ligaments, and it takes quite a bit of force to rupture them. Right? And then in between the anterior and the posterior one, you have your interocean on the right. So number 2 is the deep deltoid ligament. It actually runs from the inner part of the medial malleolus and goes into the medial wall of the talus. And number 1, so you see all that small arrows tracing it on the picture on the right, that is this component of the superficial deltoid ligament. So if you look here on the picture on the left, you see these colors, A, B, C, D, E, they're all components of the superficial deltoid ligament. So it actually just comes and attached to all the structures on the medial side of the ankle, even including your navicular bones, all the way to the anterior to the navicular bone. Okay, so the sustentaculum tali of the calcaneus and the heel on its own. Okay, I think I've seen quite a number of patients that turn up in my clinic, maybe 1 month later after the sprain, who has received some analgesia from the GP and told them, don't worry, just rest and it will settle. Okay, but you do need to be a bit more attentive to them because quite a number of them, at least 20-30% of them, in the long run still end up with chronic pain, instability, recurrent swellings, and of course we don't want to miss any occult fractures or occult injuries. Right, so what can we do? So when we first see the patient at their presentation, usually they come on the day itself or the day after or 2 days later, right? So we have to examine them properly, look, feel, move, still going back to our basic musculoskeletal examination, right? So look for any swelling. Where is the location of the swelling? Is it all on the lateral side? Is there any bruising? Is it all on the lateral side? Is there any bruising on the medial side? It gives you an idea which one is affected. And of course, ask them properly, how did they injure it? Were they just walking? Were they running? Did they go down a flight of stairs? Okay, was it during the sports? Right, so palpation, so you know your bony landmarks, palpate all of them for bony tenderness. Up there, and what causes pain there? Okay, if you have tenderness there, that would be your syndesmosis. Okay, in between your distal tibia and your distal fibula, right? Anterior distal tibia and distal fibula. Okay, you want to just move your finger up a little bit there, just above the joint line and over that place. See whether there's any pain there. Okay, how about on the medial side? Why did I circle this place? Okay, so this is on the medial aspect of the anterior joint line of the ankle, just in front of the bony medial malleolus. You would typically find a soft spot there, right? That is where the dome of the talus is, and most commonly in an inversion injury of the ankle, you can injure the cartilage of the talus, right? So most commonly when you invert your ankle forcefully like that, what happens is that talus will rock against and knock against the distal tibia, most commonly on the medial side, and you get that tenderness there, right? So if there is tenderness over the posterior aspect of the distal fibula or the posterior aspect of the medial malleolus, up to 6 cm proximally, do the ankle x-ray. If the tenderness is more over the foot, base of 5th metatarsal, navicular, you do the foot x-ray. Static tapes, some people use dynamic tapes, but anyway, some form of a protection. Okay, we'll talk about that in detail. OL is optimal loading. Now I must stress that this is a very important component and evolution of our initial management. Optimal loading means you allow the patient to wait there as they tolerate. You tell them some discomfort, a pain score of 2 or 3 is okay, alright? Optimal loading, so they should wait there as they can tolerate. Maybe the first 2 days they can't put much weight on it, but as the pain continues to evolve and resolve, you tell them, start to put more weight on it. Don't be afraid. If you're just feeling some discomfort, pain score of 2/3, put weight on it. Loading improves healing. Loading improves linear formation of ligament structures, ligaments, okay, collagen, sorry. So if you don't load the ligaments that are healing, they heal in a very haphazard way. Okay, so studies have shown that having some load on the ankle improves the linearity of the collagen fibers that are being formed. Right, so optimal loading. Okay, don't do that anymore, please. Okay, you have disuse atrophy, muscular atrophy, and all these other problems that come. Okay, so we have so many good functional braces now, and it allows patients to wait there with some degree of protection. Okay, so which one to choose? I think if it's like a grade 1 sprain, I would go for something that's much more light. Alright, I like this elastic kind of guard with this is like a figure of 8 strap that's built into it. Okay, so actually the main reason why we're putting protection, in my opinion, is that we want to prevent the ankle from going into maximal plantar flexion and inversion. We know that they've sprained their ATFL. Okay, we don't want them to heal in a lax manner. Okay, so we protect it to some degrees, making sure that they don't go into maximum plantar flexion and inversion. So technically, I do tell them you should wear your ankle guards or your braces or your boots even to sleep. Because when you sleep, your foot is like that. Okay, and when you sleep, it's when your healing happens, right? Okay, so you don't want them to end up with a chronic instability or laxity of the ankle, right? So first 2-3 weeks until the pain has subsided, they should be on some form of a brace, okay, so to prevent the extreme movement. If they are very swollen, they will shout at you for trying to stuff them into a brace. So sometimes you can opt for a boot. And also again, still the same principle. Boot is more restrictive, no movement allowed at all. Okay, but you don't have to struggle to get it on compared to like a brace. You know, have you worn ankle guards before? Sometimes they can be quite a struggle to wear, right? Especially if you are very grade 3 sprain and or like a balloon your ankle. So sometimes maybe it's better to just put them on the boot first. The boot costs a bit of money, and you do have to tell them that you're going to use it for maybe 2 or 3 weeks only. After that, they can kindly donate it to me, maybe. And then after that, they should downgrade to a functional brace. Alright? Let it heal, but we treat them collectively together with lateral ankle sprains. Alright? How about the second one? So this is a fracture of the lateral process of the talus. Very small flex like this, also we don't really need to treat. You can see it? See that? Just, yeah, that bit there. Very small flex like this, we don't really need to treat. Not working. Anyway. But if it's actually bigger, sometimes we do need to maybe surgically remove it if it's constantly causing pain chronically, or if it's big enough involving the articular surface, then we need to screw fix it. Okay. Number 3. This is one that's more hard to treat. Okay, when you have an injury or concurrent injury to the talus cartilage. Sometimes on X-ray we can see the osteochondral lesion on the medial talar dome. Okay, sometimes on the lateral side, sometimes on the medial side, depending on the injury mechanism. Okay, so these are more harder to treat. You see these on the X-ray, please do refer them. Okay, and then last but not least, anything wrong with the last X-ray? So that's syndesmosis widening. Okay, sometimes they can be very subtle. Sometimes it's good for you to get an X-ray of the other side to compare. And by rights, when you look at tibia fibula overlap, and everything, but probably one measurement that you can go home with and remember is this one, which is the space in between the, it's called the syndesmotic clear space. Okay, so it should be measured 1 cm proximal to the dome of the talus, and it can be measured in both AP and Mortis view. The measurement, the numbers is the same, so it doesn't differ. Okay, so it should be 5 mm less on these two views, either one of these views that you're doing. Alright? Okay, braces actually in Decathlon. I'm not an ambassador, but they only cost 60 ringgit. For the functional brace in Decathlon, 60 ringgit anyway. So the brace is basically should be worn during sleep as well to prevent the extreme plantar flexion and inversion. Alright? You should review them back at 1 week. See if there's anything you've missed. Because when the symptoms, the pain comes down a little bit more, the examination can be more focused and target things that might have been masked by the initial extreme swelling and pain. Okay? Look hard for syndesmosis injuries. These are hard to treat if they become chronic, if they become missed. Okay, if they are gapping and they've become chronic, it's very hard to treat. Right? So keep the brace on maximums for the 6 weeks and progress to physiotherapy. Right? Thank you.
So you know you're tuning for, assess for whether the proprioception is whether patient is aware whether the toes are up or down. You remember that, right? And also, of course, your monofilament, the 10-gram monofilament test. That means you want to put it on the dorsum of the big toe and then move upwards and then look both sides whether it's symmetrical. Usually, if you get a glove and stocking distribution, then you know this patient has peripheral neuropathy, and therefore it's a clinical diagnosis. You don't have to send the patients to do a nerve conduction study to confirm it. But if you find it is not very typical, it might be more severe in one side, you see muscle wasting more in one side, you might want to refer for nerve conduction study or even EMG to a neurologist. Okay, alright, so begin screening at diagnosis for type 2, but after 5 years in type 1, because we know the microvascular complications usually happens 5 years after diagnosis for type 1. Many years, and you and I may already be in a pre-diabetic stage if you're not diabetic yet, and the pathophysiology just doesn't reverse over a few years. So, but we can get it into remission. That means we can get a patient to maintain normal glycemia when we get the insulin resistance under control. And therefore, what is happening now, we have medications like GLP-1 receptor agonist that is able to reduce the weight. So just like I mentioned, 10 to 15%. So all these new medications coming with potential of weight loss up to 20% has the potential to get the glycemia to target very easily. I'm sure you have tried it yourself. Some of you either on yourself or your patients, and you can see the weight does go down. Of course, there is a plateau, and when there is a plateau, sometimes when the patient removes the medication, that's when not only the weight rebounds, but the glucose control rebounds to abnormal. Okay, that's talking about glycemic control. And also you have to know that microvascular complications is also contributed by blood pressure and your lipids. Okay, majority of all the wrong information that lipids and statins causes complications. I get that a lot from my patients. Sometimes the GPs or the doctors, who family doctors, concur with them that says that, hey, you know what, lipids are bad for you. You know, if can, you try diet and exercise. Try to use other methods to reduce your cholesterol. I want to tell you, we live in a very obesogenic environment. Our food are very rich in oil. Whether you're Malay, Indian or Chinese, it's a lot of oil. And of course, if you're going to eat healthy for a few days or 1 month, that's not going to get your cholesterol down. Okay, I think if the best diet intervention I've seen also get it down to 1 LDL by 1 or 2 the most. Alright, we are talking about getting LDL from 5 to less than 2.6. Who does that best, if not statins? And we're talking about high potential efficacy statins okay. Alright, you're talking about atorvastatin and also rosuvastatin. Okay, and always, if you're going to treat it properly, Don't do, I give you a low dose, you just need it a little bit low. Get it to target. We have targets. The targets are there because of research and guidelines that shows that when it's less than these numbers, then so you know your targets, right? So if it's just patients just diagnosed with diabetes, not beyond 5 years, the target is 2.6. Patient feels better and happier also. So
Duloxetine start with 30 milligram and then can increase up to 60 milligram.
And still
Duloxetine.
it doesn't help the patient. Sometimes we try combination. That means we can give duloxetine and pregabalin together.
First line is duloxetine
Or
and
these
pregabalin.
two combination doesn't work, you try another first line therapy like amitriptyline. If all these three doesn't work, then you can consider giving opioids. There's also a role of 8% capsaicin cream, which I don't know whether any of you have experience using it.
Capsaicin.
This topical cream, capsaicin cream that treats neuropathic pain as well. Anybody used this before? Because I have no access. I had somebody come to me not too long ago asking about whether I would want to use it. I said yes. Then after that I said we are thinking of bringing it in, but it has not come back. Zymes. So as you can see, the numbers are not significant. P-values all are not significant. So there's no alarm to be ring about giving too much via nerve. Usually we don't go beyond 2 tablets a day. Okay. Alright, so does it help with the dysglycemia? I mean, improve indirectly our metabolic parameters, yeah, because of this very high potency of antioxidant in it. High heels and that causes friction and blisters. Try to use white shoes if possible, and all the extra strappings if can to be avoided. Okay, all right.
In UK now, there's a 6-page form that we have to fill every time we do people on our thing, and literally scan them away, and then they end up not skin, but I think it's underdiagnosed in darker skin tones because it's very hard for us to see the erythema. And I definitely have had in the last few months
comedones.
2 people who have had rosacea with darker skin tones. It's just you need to know what to look out for. So there is a score. Actually, can I use this? But the score, which is in the NICE guideline, is global rosacea consensus. So if you have one diagnostic, which is your central facial erythema, and 5 meters change. So people get hyperplasia of the tissue, and usually around the nose, and usually men. They will get it worse than women. And if you have 2 of these major phenotypes, which is papules and pustules, and that's why this is always confused with acne, is because of the papular pustular element of it. But these patients usually will say they get flushed. So ask for, you flush after a hot shower, and then there are other triggers which I'll go through. Now, the other thing is we also treat them with Roaccutane. The same way as we treat acne, we usually use isotretinoin as well, but slightly differently, we would use low doses because they have very sensitive skin. Because what isotretinoin does is it really dries out the skin, so they generally do not tolerate it as well as the acne patients. We will put them on low doses and we will put them on it longer. So they might be on it for a year, but it still does the same thing. It reduces the spots. Now, this treatment has been in the UK for a very long time, maybe 10 years, but it's still not in Malaysia yet. I'm a very big fan of this. I put all my rosacea patients on this at nighttime, and I will give them azelaic acid in the morning, even if I'm giving them oral antibiotics. And this is ivermectin. Because of that theory that Demodex mites are the ones causing the inflammation, and the Demodex mite burden is higher in those rosacea, Soolantra works really well, and especially those type of people with rosacea that have overlap with seborrheic dermatitis. Because if you see a lot of rosacea, you realize that a lot of them have this overlap with seborrheic dermatitis. Those are the type of patients where this works really well. And I've been told it will be in Malaysia in 2027. Okay? It's a free use to nighttime, up to 4 months. Go through skincare as well. So one thing you can do, and tip and trick for patients with redness, is to use a sunscreen that has a green tint. That will reduce the redness. And these patients will obviously react more to the sun, so you get them to wear sunscreen. And also one of my patients here with a pustular ring on her cheek, who was, this is the other thing. If you have a symmetrical rash, it's very unlikely it's going to be an infection. Infection usually is asymmetrical. Now this patient went to their GP, had a few pustules or weeping on both cheeks, was told that this is an infection, kept being given topical antibiotics, topical steroid, that's the key word, and eventually she presented to me like this, and this is rosacea fulminans, where you have such, edema, pustules, and it feels, really hot to touch. Look, steroid is actually one of the things that brings up acne and rosacea in a lot of patients. This type of rosacea, same with a very severe type of acne, can be associated with inflammatory bowel disease. And this patient had to be put on oral steroids with isotretinoin to bring everything down. So like I said before, three doctors can be in charge of patients with rosacea, either dermatologists for the skin, plastic surgeons will usually help with their rhinophyma, either by doing CO2 laser or the papulopustular component. So the main thing, like I said, is the comedones.
Comedones are
Generally,
differentiating.
rosacea will not have comedones.
Rosacea has no.
Redness in the background, telangiectasia, eye involvement, and they have more sensitive skin type. In terms of location, it's pretty much the same: face, chest, back, but with rosacea you also see it on the scalp and age group. So think, if you're seeing a female in their 30s, could this be rosacea? Now I'm going to go through cases that mimic acne, okay? Acne mimickers. So this is a 35-year-old patient who gets spots around. Sometimes we think it could be their sunscreen, sometimes we think it's hormonal, but one of the triggers, if you ask in the history, is they've usually been given a steroid to put on the face, and then suddenly this rash breaks out. Treatment is very similar. We usually give them oral antibiotics. Topical treatment is very similar as well. Only with these patients, sometimes we give them pimecrolimus or Elidel to reduce the inflammation. And if we need, we give them low-dose isotretinoin as well. Another case, 20-year-old man, itchy papulopustular rash on their chest, back and buttocks, painful, has been going to the gym, sweating more. This is folliculitis, okay? The term folliculitis itself means inflammation of the follicle. So you can get folliculitis on the face, and that could be folliculitis. For example, when people shave, they get a rash afterwards, you can get some people. It doesn't mean that they have an infection, it just means their hair follicles are irritated. But you can also get bacterial folliculitis. You can also get gram-negative folliculitis from hot tubs and spas. So if you're treating folliculitis, it's not getting better, always try and swab it. In fact, the hot tub folliculitis usually gets better on its own with time. Just know that that's another diagnosis. Again, on social media, due to social media, everybody kept coming thinking that they have fungal acne. But actually, fungal acne is not really acne. It's folliculitis caused by Pityrosporum, which is a yeast, same yeast that causes dandruff, same yeast that causes pityriasis versicolor, or in Malay we call it panau, which is uniform, itchy. So the way you differentiate it is usually they have comedones, and it almost looks like a sheet, and all the papules look the same. So think to yourself, and usually they'll say it's itchy, which is not very common with acne. So these patients need basal creams or itraconazole or fluconazole. Another common case that I see is people being referred to these abscesses in their groin, under their arm, and usually these patients are obese. This is not acne, okay? This is hidradenitis suppurativa, or the other name is acne inversa. Now these patients who come with boils in these particular areas, which is usually under their arms, groin, under the breasts, it usually takes them about 10 doctor visits to actually get a diagnosis. They'll usually get one abscess, go to Access University, get it drained, pour in a course of antibiotics. Then in a few months they'll get another one, and it's only until it clicks, because now they suddenly have a lot of scarring, a lot of sinuses, that this is actually a skin condition called hidradenitis suppurativa. Usually starts during puberty. There's usually a very
strong. We all do prescribe prenatal vitamins, and the commonest prenatal vitamin we all prescribe, but women take it much later, is the folic acid. Okay, so that's why we are not concentrating on the regular vitamins we are prescribing already, but of course I'm sure most of us are prescribing. But the know-hows of when to prescribe and when not to prescribe and how much to prescribe is what we are going to touch upon this. So prenatal vitamins, we all know, are very crucial during the first and throughout all the trimester. Okay, nowadays we do talk a lot about omega-3. That is why in this lecture we are discussing both iron as well as the omega-3s. Okay, how important and crucial they are to a growing fetus. Okay, so we do not have any specific recommendations here in Malaysia. But does that mean it's not important? Definitely, that's what we're gonna see. See, what is DHA and EPA? I know the names sound like three people. Again, are iron deficient, especially the ladies here. And let me show the statistics. Again, in third trimester, know about the signs and symptoms of iron deficiency. So you don't have to try wanting symptoms. Okay, again, look at this. They put a dot for the hair loss alone. If your ferritin is only 70, okay, so you can still have a hair loss. And how much do we normally say for iron deficiency anemia? How much of ferritin? What is the classical definition for serum ferritin? Low serum ferritin is how many milligrams?
70.
Usually we say 30, not milligram, nanogram per ml. So less than 30 we always classify as iron deficiency.
30
But look at
nanogram.
this, when your ferritin level drops to 70 itself, you have all the hair loss and other symptoms, and the fatigue. Even when your serum ferritin is about 100, you still have fatigue. Okay, so that is why your hemoglobin sometimes may look normal, but you might be still iron deficient. That's why ferritin levels are very, very important. Why do we have to care about iron deficiency anemia? Okay, again, when you're talking about pregnant, meet their recommended nutritional intake. And what fad was daily intake of omega-3 fatty acids. 92% of subjects did not meet their RFI again has, okay, my hemoglobin is very low. So instead of taking 2 pills, there are 2 extremes of patients. One patient will not take how much ever you tell. They feel, that iron is making them very nauseous, so they will avoid taking. Another will think that taking more is better. Okay, so both are wrong. So maximum you go for 2 tablets or 3 tablets actually is recommended dose. But sometimes what happens is when you take more tablets, your body can absorb only that much. And also your hepcidin hormone will come and block your iron absorption. Okay, also. So all this will prevent absorption. Just because you're taking 6 tablets of iron in one day, your hemoglobin is not going to multiply rapidly. Okay? So 2 or maximum 3 tablets of iron is more than sufficient.
Maximum 3
In
multiple
fact, 2 itself
per
is
day.
more. And the more you put, sometimes the gastrointestinal side effects may increase, constipation. So that is why we should be very wary of how much iron we are giving. For a woman, she says, no, I cannot tolerate it at all. What you can be once a week dosing instead of totally having nothing. Okay? So you can try all these forms of
Alternate
oral
day
therapy
for
before we
pregnant
go in
women
for
that cannot
nothing
tolerate
worse, then of course we have to go
alpha
for IV iron.
or iron
That is
supplement.
later, despite oral therapy, if it fails. Okay? So don't take too much of iron. Take iron properly in the proper interval. If they cannot tolerate it daily, you can use alternate day or twice a week dosing. Okay, so again, another they give IV iron and within 1 week or 10 days, you check the hemoglobin back. Sometimes, you won't see a raise because for your hemoglobin, for your red blood cells to form, it takes 21 days. So you need at least 3 to 4 weeks interval before you can know whether the supplement is working or not. So at least give at least 3 to 4 weeks interval before you check your repeat hemoglobin. And if it's totally not increasing, again, hemoglobin alone is not an indicator for iron deficiency. That is why you have to do your, what test do we do? Ferritin levels. Okay, ferritin levels are very, very important. Even with a patient who has normal hemoglobin, anything more than 11 grams is not anemia. But what happens is these women still have very, very low ferritin. When you have low ferritin, these are all the signs and symptoms. So it looks like a classical iron deficiency anemia. Or there in your own la la land. This is what you need to take home. Okay, this is a summary of whatever we have discussed. Okay, so prenatal supplements are essential not just in first trimester. Most prenatal vitamins, remember, do not contain adequate DHA. So you need to make sure that the supplement they take is sufficient in DHA. And again, the stop and starts for you GPs who are seeing you who are the first tier of management of pregnant women, stop treating hemoglobin alone, assuming that prenatal vitamins cover DHA. Okay, so stop assuming these two things and start checking for ferritin, asking about diet and individualizing supplementations. And if a woman comes to you later in pregnancy, still not started on all these supplements, better late than never.
The tablet name Serenate.
Yes, CERENATE. That's based from, it's taken from seaweeds, algae based.
Vegetarian, primarily.
Flaxseed. Yes, flaxseed is good, but has anybody taken flaxseed? Do you take? Yes, flaxseed oils, but again, flaxseed, sometimes people have this, they cannot tolerate flaxseed as well. Especially me, I have tried flaxseed oil and I hated it. Flaxseed powder.
Okay.
The problem is we don't know how much of milligrams. Do you think if there is enough DHA and EPA? Because omega-3 has alpha-linoleic acid also. That is also classified as omega-3. But ALA does not get converted very efficiently in EPA and DHA. Flaxseed has more of ALA. So we need to see how much of equivalent of DHA and EPA is in that.
Very interesting your talk. Regards of choice of, you talk about fish oils and everything. So today in the market, there's many products around. So in our country also, autistic child, the numbers also growing up. So now fish oil, there are many studies also. Certain fish oils contains high mercury contains, and so. How you know? Definitely you, because it seems you have a regenerative degrees, and so you know the choice and everything. How you choose the right products? So second question is, how we know that whatever the vitamins and everything is actually absorbed into the Malaysian guts? I think there's new studies that says about 60 or 70% we are absolutely, we have a leaky gut syndrome. So how to go along with this?
Okay.
Thank you.
Very valid questions, because most of the patients, some of them are already taking fish oils. So they are going to ask us, can I continue the same? Or my husband is taking this fish oil. The pregnant women will ask. Okay, and there are umpteen number of fish oil supplements. See, fish oil, there are two types of supplements. One is taken from the fish body and another is from the fish liver. Okay, or the cod liver oil or your 7 Seas oil, which traditionally our parents used to take and give us. Okay, the cod liver supplements. Cod liver oil you cannot give in pregnancy because of high vitamin A content. Vitamin A, though it is a vitamin, it is highly teratogenic in high doses. Okay, and omega-3, again, the more amount, just because it's good doesn't mean you should take a lot. More than 3 grams you cannot take. It's actually toxic, and it also thins your blood. So when you're taking any supplements, sometimes we put them on aspirin and all that, so we need to be cautious. So you always go for a supplement which is highly purified and pregnancy safe. Okay, so you need to look in the ingredients, where is it taken from? Is it a fish body oil or a fish liver oil? If it's a fish body oil, how is it purified? Whether it is highly purified, you will have certain, the Alaska, it will tell in the ingredient list, it's from Alaskan fish and it's highly purified, devoid of mercury and all that, they will put that. And they will put specifically, nowadays you can ask ChatGPT or Google search that particular brand, whether it is pregnancy safe. That's the first thing. The second one is,
Leaky gut.
absorption, yes, okay. The bioabsorption or your bioavailability, omega-3 and omega-6 ratio we can actually test, but of course in pregnant women it is easier to supplement and then look for clinical effects. So when we are supplementing for say low birth weight, like the last case we saw, if the baby's weight is improving, then yes, she is getting enough. So that is why there are practitioners who go by, we start with 2 or 3 capsules first and then we increase actually the omega-3 based on how the baby is responding. Okay, so again, it's not one size fits all. So one is, yes, there are omega-3 and omega-6 studies available. These are specialized tests. You have to request for them. and the ferritin levels. So yes, the ferritin is a marker for iron deficiency. So we have and TSAT is for people with chronic inflammation. So if for us, if you're thinking about leaky gut and all that, you have to check CRP and TSAT levels. These are more predictive of iron deficiency rather than ferritin levels. Ferritin is actually becoming outdated, but that's the easiest and the least expensive test, so we use that. And there's another one test called as the newer one, soluble transferrin. Okay, that is the latest, but it's not easily available in Malaysia.
Okay, I think that should be enough.